3 surgeons, same patient, same recommendation. Not one of them timed how long it took him to walk across the room. That walk, 3 meters out, turn around, 3 meters back, sit down, takes less than 10 minutes to assess. It has a name. It has decades of research behind it. And in this man's case, it would have changed everything his surgical team told him. This is not a story about a bad doctor. This is a story about a gap between what medicine now knows about surgical risk and what most patients are ever asked to do before they sign a consent form. Nobody told you that gap exists. Nobody told you there is a test your body needs to pass that has nothing to do with your labs, your imaging, or your cardiologist's clearance letter. Today, that changes. Write this down.
My name is James Reyes, and this channel exists for one reason: to give you the information your doctor's appointment doesn't have time for. If you are over 60, or if someone you love is scheduled for any elective surgery this year, stay with me through this entire video. What I am about to show you could be the most important conversation you have before anyone picks up a scalpel. Drop a comment right now with just your age, nothing else. I want to see who is watching this. Here is what the system assumed for decades. If you passed the basic preoperative workup, blood pressure under control, cardiac clearance in hand, labs within range, you were ready for surgery. Age was the variable everyone worried about. 70 years old, 75, 80. The older the number, the higher the caution. But age is a terrible predictor of what happens after surgery. 2 people can be the same age and have completely different bodies. One walks 3 miles a day, climbs stairs without thinking, carries her own groceries. The other gets winded going to the mailbox, grips the wall when she stands up too fast, and has lost 12 pounds in the past year without trying. Give them the same operation, and you will get very different recoveries. The system knew this. Researchers knew this. What the system did not do for a very long time is give that difference a name, a measurement, and a place in the preoperative conversation. That name is frailty. And here is what frailty does not mean. Frailty does not mean old. It does not mean sick. It does not mean your life is winding down. In clinical medicine, frailty is a specific, measurable syndrome, a reduction in physiological reserve across multiple organ systems that makes the body more vulnerable to stress. Surgery is one of the most concentrated biological stressors a human body can experience. Anesthesia, blood loss, inflammation, infection risk, days of immobility. The body needs reserve to absorb all that and bounce back. When that reserve is depleted, the body cannot bounce back the way the surgeon's outcome statistics assumed it would. This is education, not medical advice. Everything in this video is designed to help you ask better questions, not to replace a conversation with your own surgical team. Now, here's the number that stopped researchers cold. A team at Wake Forest University School of Medicine tracked 33,439 patients, all of them over 55, all of them undergoing elective non-cardiac surgery, and looked at what happened to them in the weeks that followed. They published their findings in JAMA Network Open in November 2023. What they found: patients classified as pre-frail had significantly higher odds of postoperative adverse events than patients classified as fit. Patients classified as frail had even higher odds across the board. Higher rates of unexpected ICU admissions, higher rates of 30-day readmissions, higher rates of transfer to a skilled nursing facility instead of going home, higher in-hospital mortality. 33,439 people, not a small study, not a preliminary signal. The kicker? Nearly half, 47.6%, were classified as pre-frail before their surgery, and 17.8% were classified as frail. That means roughly 2 out of 3 patients walking into elective surgery at Wake Forest were not in the fit category their outcome statistics were built around. Nobody told them that. The guidelines their doctors followed were designed for fit patients. Nobody told you that either.
Before I get to what you can actually do about this, and there is a lot you can do, I need to show you exactly how frailty is measured. Because once you understand the 5 markers, you will never sit in a pre-op appointment the same way again. Write this down. In 2001, a researcher named Linda Fried and her team at Johns Hopkins published a paper that would quietly reshape how medicine thinks about aging and surgical risk. The study followed thousands of older adults over time and looked for a pattern, a cluster of physical signs that predicted who would decline, who would be hospitalized, who would die. They called it the frailty phenotype, and it identified 5 specific markers, not lab values, not imaging findings, physical signals the body sends before the bigger problems arrive. The 5 markers are these: unintentional weight loss, losing 10 pounds or more in the past year, not a diet, not a decision, the body quietly burning through its own reserves. Exhaustion, not ordinary tiredness after a long day, a persistent sense of low energy that doesn't resolve with rest, feeling that most things require more effort than they should. Grip strength, measured with a handheld dynamometer, a device that looks like a small handle you squeeze. Grip strength is one of the most underrated markers of overall physical reserve. Research has consistently shown it predicts surgical outcomes, falls, hospitalization, and long-term mortality better than most lab panels ordered before surgery. Slow walking speed, measured across a short course, typically 4 meters. The clinician times how long it takes you to walk it at your normal pace. Not a race, just your walk, how your body moves when nobody is asking it to perform. Low physical activity, measured in kilocalories expended per week, not whether you exercise, but whether your daily movement falls below a threshold that keeps the body primed and responsive. Score 0 of 5, you are robust. Score 1 or 2, pre-frail. Score 3, 4, or 5, frail. That is the framework published in 2001, and it is still the reference standard for frailty research worldwide. Now, here's where the story gets harder to hear. Most surgeons are not running this assessment before elective procedures. Most preoperative checklists do not include grip strength testing or gait speed measurement. Most patients receive a medical clearance letter that says their heart is stable, their blood pressure is acceptable, and their kidneys look fine, and walk into the operating room never having been asked to walk across a room while someone held a stopwatch. That gap between what the evidence now recommends and what actually happens in most preoperative visits is real. It is not unique to one hospital or one region. It is systemic. And the researchers who've spent the last decade documenting it are increasingly direct about what it costs. A study from the VA system looked at what happened when frailty screening was added to the surgical workflow at Omaha VA Medical Center. Before the screen, mortality among frail veterans scheduled for surgery was running at 25%. After implementing routine frailty assessment, that number dropped to 8%. Not because anyone discovered a new drug or a new surgical technique, but because the conversation changed before the procedure began. Some patients were directed towards prehabilitation, some procedures were modified, some were postponed, some were reconsidered entirely. The assessment did not prevent surgery. It prevented the wrong surgery at the wrong time for the wrong body. Nobody told most patients that option existed. There's a second test worth knowing about.
It's even simpler than the Fried criteria, and it can be administered in any clinic with a chair, 3 meters of floor, and a stopwatch. It's called the timed up-and-go test, and in perioperative medicine, it's become one of the most practical screening tools surgeons and anesthesiologists have at their disposal. The test works like this. You sit in a standard chair with your back against the seat. On the word go, you stand up, walk 3 meters to a line on the floor, turn around, walk back to the chair, and sit down again. The clinician times the whole sequence. No equipment required, no blood draw, no imaging order, just you, a chair, and a floor. Healthy older adults without major mobility concerns typically complete this in under 12 seconds. Results above 12 seconds are associated with elevated risk of functional decline following hospitalization.
Studies in surgical populations have found that patients taking 15 seconds or more show meaningfully higher rates of postoperative complications, longer stays, and lower rates of returning home without assistance. Here is the other fact that stops people. That test takes less than 2 minutes to administer. Most preoperative visits include a blood pressure cuff, an EKG, and a list of current medications. They do not include a stopwatch and 3 meters of corridor. Your doctor may not know this yet. The research is that new, or rather, the adoption is that slow. Drop a comment right now and tell me, has any surgeon or pre-op nurse ever asked you to stand up and walk across the room as part of your clearance for surgery? I want to know how many people watching this have already had this conversation. So here is the question most people never think to ask. If frailty is this measurable, this predictable, and this consequential, why isn't every surgeon running this assessment before every elective procedure? The honest answer has 2 parts. The first part is time. A standard preoperative visit is built around a checklist that was designed decades ago, optimized for cardiac clearance and anesthesia risk, and has not been systematically updated to reflect what the research now says about functional reserve. Adding a gait speed assessment and a grip strength test takes minutes. Integrating them into a workflow that wasn't designed to receive that information takes institutional will that most systems haven't yet applied. The second part is harder to say out loud. Frailty is reversible, at least in part, and the system has not yet built the infrastructure to act on that fact in the time window between a surgical recommendation and a scheduled procedure. Nobody told you that either. Here is what reversible means in this context and what it does not. Being classified as pre-frail or frail before elective surgery does not mean your body is broken. It does not mean you're out of options. What the evidence increasingly shows is that the weeks between a surgical recommendation and the procedure itself are not empty waiting time. They are a window. Write this down. That window has a name in medicine: prehabilitation. Prehabilitation is not physical therapy after surgery. It is targeted preparation before surgery, designed to increase the body's physiological reserve so it has more to draw on during recovery. A growing body of research, including studies reviewed by the Society for Perioperative Assessment and Quality Improvement, shows that multimodal prehabilitation programs, combining structured movement, nutritional optimization, and in some cases cognitive support, can meaningfully improve how frail and pre-frail patients move through surgery and its aftermath. The components are specific: resistance training to rebuild lower limb strength, walking protocols calibrated to current functional capacity, protein intake targets that counteract the muscle-depleting effect of surgical stress. In some programs, inspiratory muscle training to improve respiratory reserve before the anesthesia clock starts. None of this is experimental. The research is there. The programs exist. What is missing for most patients is the conversation that connects the frailty assessment to the prehabilitation option, because that conversation requires someone to have run the assessment in the first place. A recommendation is not a verdict.
and a surgical date is not necessarily a deadline that cannot move. There is one more piece of this that the standard pre-op visit almost never raises. Frailty classification does not mean surgery should be refused. The evidence is clear on this, and it is important enough that it belongs in this video directly. Being identified as frail before a procedure means the surgeon team now has more accurate information. What they do with that information depends on the procedure, the patient, the goal, and the alternatives. In some cases, the procedure moves forward with a modified approach, minimally invasive techniques where open surgery was initially planned, adjusted anesthesia protocols, extended postoperative monitoring. In other cases, the team decides to delay and implement prehabilitation first. In others, the conversation shifts toward what the patient actually wants from the surgery, not just whether it is technically feasible, but whether the expected recovery aligns with the life they are trying to protect. That last conversation is called shared decision-making. It's considered best practice in perioperative medicine for older adults, and it almost never happens unless someone first runs a frailty screen.
If your surgeon told you that you were pre-frail and that 4 to 6 weeks of structured preparation could meaningfully reduce your risk of a complicated recovery, would you want that window? Drop "window" in the comments if that option would matter to you. You are not a passive recipient of medical decisions. You are an informed participant in your own health. And that means you can walk into the preoperative conversation with better questions than the system was designed to expect from you. Here are 3 concrete steps, each one specific, each one actionable before you or anyone you love signs a consent form for elective surgery. Step 1. Ask for a frailty screen. Not a cardiac clearance, not a lab panel, a frailty screen, by name. The most practical tools your surgical team can use include the timed up and go test, which takes under 2 minutes and requires nothing but a chair and a corridor, and the 5-item frailty criteria, which can be completed during a single clinical visit. If your hospital system uses an electronic frailty index built into the health record, as Wake Forest Baptist and an increasing number of major U.S. health systems now do, that score may already exist and simply not be surfaced in the preoperative conversation. Ask for it. The research supports it. The Society for Perioperative Assessment and Quality Improvement formally recommends frailty screening as part of preoperative evaluation for older adults undergoing elective, intermediate, or high-risk surgery. You are not asking for something experimental. You are asking for something the evidence has supported for years. Step 2. Ask what your result means for your plan. If you are classified as robust, the conversation confirms your readiness. If you are pre-frail or frail, the conversation should not end there. It should open. Ask whether prehabilitation is an option before your scheduled date. Ask whether the surgical approach can be adapted to your functional profile. Ask what the expected recovery looks like for someone at your frailty level, not the average patient in the outcome statistics, but someone with your specific markers. A surgical team that has run a frailty screen has more information. Make sure that information is being used. Step 3. Ask the most patients never ask. What happens if we wait 4 to 6 weeks? For most elective procedures, a short delay to implement prehabilitation carries minimal clinical risk. For some, it carries meaningful benefit. The research from the VA system alone, showing mortality among frail surgical patients dropped from 25% to 8% after systematic frailty screening and intervention, is not a small signal. It is a large signal that most patients never receive because no one framed the preoperative window as an opportunity. You now know it is. Let's recap what this video covered. Frailty, not age, is the real predictor of what happens after surgery.
It is defined by 5 measurable markers: unintentional weight loss, exhaustion, low grip strength, slow walking speed, and low physical activity. It can be assessed in under 10 minutes. It predicts ICU admissions, readmissions, discharge to nursing facilities, and mortality better than most standard preoperative labs. And in a study of 33,349 surgical patients published in JAMA Network Open in 2023, nearly 2 in 3 patients were not in the fit category the system's outcome statistics were built around. Nobody told them that. You are now one of the people who knows. Drop "informed" in the comments if this video changed how you think about the preoperative conversation. And if someone you know is scheduled for surgery in the next 6 months, share this with them. The conversation they have before they sign could be the most important one they have. Next video, we are going to look at what happens when your surgeon recommends an operation and what questions to ask before you agree, because surgical clearance and surgical wisdom are not always the same thing. This video is for educational purposes only and does not constitute medical advice. Frailty classification requires clinical evaluation by a qualified healthcare provider. Always consult your surgical team, primary care physician, or a geriatric specialist before making any decisions about surgery, prehabilitation, or changes to your care plan.